I'd like to thank the organizers for giving me the opportunity to present on emerging infections and biosecurity. These are my disclosures. So the global health security agenda is really an effort from countries to prevent, detect, and respond to avoidable epidemics and other biologic threats. Regarding biologic threats, this could be everything from outbreaks to formal acts of bioterrorism. However, what we know is that most countries are not prepared. In fact, just prior to the COVID-19 outbreak, the Global Health Security Index conducted by Johns Hopkins University showed that countries on average were about 40% prepared for a future pandemic. And some of these diseases are quite dangerous. The WHO lists priority diseases that could result in a pandemic. But unfortunately, for many of these diseases, there is no therapeutic. No licensed countermeasures exist for diseases like CCHF, Crimean Congo Hemorrhagic Fever, Ebola, Marburg, Lassa. And you can even see that some of the other diseases that were considered in the 2018 revision included a highly pathogenic coronaviral disease other than MERS and SARS, which is the pandemic that we now face. And why is this important? It's because we all live in an interconnected world. Humans, domestic animals, wildlife, and the environment all carry pathogens, and we can exchange these pathogens and bring about diseases that are both known and unknown. And one of the big concerns we have right now is something called zoonotic spillover. Pathogens that primarily infect animals finally getting into the human population and causing large outbreaks. Now, sub-Saharan Africa faces a lot of challenges when it comes to zoonotic spillover. It's rapidly developing in terms of economic growth. And so what we see is that a lot of encroachment into wildlife habitats is happening as urbanization or agriculture occurs. And at any point in time, there are multiple outbreaks that are monitored by the WHO Africa region that are ongoing. And we can see diseases that we thought were forgotten, like monkeypox, coming back. Diseases like Ebola still wreaking a toll, and other diseases like plague that we thought we had better control of. And fragile states and insecurity are one of the big challenges that we face. When you have fragile states and insecurity, it leads to economic displacements and it leads to physical displacements of people. And this could lead to overcrowding in refugee settlements and further fuel the spread of outbreaks. Western countries are very aware about the impact of rumors and myths on the potential to cause outbreaks and to actually hinder the control of outbreaks. And we've seen this in measles worldwide. In Africa, rumors around the polio vaccine caused a delay in controlling that outbreak for more than 15 years. And we're seeing the same thing with COVID-19. In addition, we also have a situation where there are inadequate health workers to manage these threats. And even if you had a large outbreak, you may not have the required personnel in hospitals to manage critically ill patients. I'm giving an example of Uganda. In Uganda, between 2016 and 2018, we see many of these diseases that are on the priority list of WHO. And currently, Uganda is in Ebola preparedness because there's an 11th outbreak of Ebola in DRC. There's an ongoing outbreak of yellow fever in Uganda. We haven't got on top of the measles outbreak, and we're also trying to manage the COVID-19 outbreak. Managing this in health facilities where infection control is weak is a major challenge and ensuring that some of our facilities strengthen IPC practices is one of the key aspects for disease control, not just for outbreaks, but in routine settings. Now, countries cannot prepare without a plan. As I said earlier, well, 40% was the score worldwide. But for developed countries, that was as high as 50%. But for developing countries, preparedness for outbreaks was even less done. And for Uganda, we have to think about two main conditions: viral hemorrhagic fever syndromes like CCHF, Rift Valley fever, Marburg, and Ebola. And also, we also have to think about pandemic acute respiratory infections, such as pandemic influenza, COVID-19, and unknown respiratory pathogens. And this really applies to all countries. Typically, outbreaks are the responsibility of government. And really, when you think about an individual trying to make a difference, it's often hard to see how that comes about. But one of the strategies we've been using is to think about institutions and how institutions can align with government to help to prevent outbreaks. Despite my clinical pharmacology training, I had the opportunity to work with WHO on infection prevention and control during the Ebola outbreak in 2015. On returning to my institute at Makerere University in Uganda, we had to review our strategy and realize that these outbreaks could happen in our settings. And yet, as academic organizations, we didn't have a clear program to intervene or support governments where these outbreaks to occur. The Institute established a new program called the Global Health Security Department. And it broke down its efforts into laboratory biosafety biosecurity, really helping to detect threats earlier, and then field epidemiology that could support surveillance and investigation, and then treatment. Notably, we did not try to separate things out and focus only in one area, mainly because gaps in each of these areas could undermine efforts in the other areas. Here, I'm going to talk about responding to viral hemorrhagic fevers in Uganda. In 2019, Uganda had a spillover of outbreaks from DRC, resulting in 4 cases and 4 deaths. However, there were no transmission chains in Uganda. The 10th EVD outbreak in Democratic Republic of Congo was the second largest outbreak of EVD, and it occurred between 2018 and 2020. About 3,000 people were affected and 2,000 people died, despite the availability of vaccines that were used to control the epidemic. However, this outbreak brought us important information because the first randomized controlled trial of therapeutics for Ebola was done in this outbreak. The interim analysis at 681 patients showed that monoclonal antibodies, MAB114, and a Regeneron product, EB3, were superior to ZMapp. These drugs were also superior to a drug called remdesivir, which had been used and shown some kind of benefit for management of Ebola in terms of primates, and preclinical studies had also suggested it would have benefit. And so it was surprising that it did not really perform well in this randomized controlled trial. For us in Uganda, it became necessary to prevent this spillover, and the approach that was used was to map out all the areas that would potentially have cases coming in from DRC. And this was done with a mapping process with the CDC country office called Population Connectivity Across Borders. Essentially, you do interviews and find out where people crossing from DRC into Uganda are most likely to go. And then you equip those hospitals and prepare surveillance sites in those areas man border points to ensure that people who may have the disease are detected early, brought to a health facility, and given treatment. But you also need to train healthcare workers on how to manage outbreaks for dangerous pathogens. The use of PPE or personal protective equipment like this is critical, not just when they put them on, but more importantly, how they take them off. And drills are critical. Healthcare workers need to practice on an ongoing basis and learn how to use the tools that they have to ensure that they keep themselves safe. Here we see a cholera unit that was actually repurposed to support isolation for suspected patients with viral hemorrhagic fevers, and the drills that were performed to ensure that the staff can keep themselves safe. But platforms are emerging that will allow therapeutics, novel therapeutics, to be tested. And here, our institute works with the US Department of Defense to establish a trial site that allows us to implement medical countermeasures in a safe manner. It's highly equipped with an isolation lab, an isolation ward, and highly skilled personnel that perform drills weekly on infection prevention and control systems. Let's look at a second outbreak, and this is the one that we may all be more familiar with, which is COVID-19. Over 5,000 cases have been reported in Uganda and 60 deaths. Importantly, as much as 2 months ago, there were no deaths in Uganda. And this was due to aggressive control efforts right from the beginning. And Uganda had to put up quite a number of measures in place to manage COVID-19. As I said earlier, healthcare capacity was limited. In fact, prior to the outbreak, the publication reported only 55 intensive care unit beds, most of which, of course, were occupied. Our institute, working with the government, was able to provide staff to support the situation room, to participate in national task force events, but also to support government in drafting out laws that could help in control efforts for COVID-19. In addition, we used a model that had been implemented for Ebola and expanded that nationwide, ensuring that every facility in the districts is reached, and working with partners for HIV and other sectors to see that health facilities undergo mentorship to strengthen their infection prevention and control practices. Laboratory testing was critical for Uganda's response. Initially, much of the testing was done at points of entry to prevent the spread of COVID-19 from other countries into Uganda. And so Uganda, fully landlocked, established over 27 sample collection sites at its borders, and then put out mobile testing labs so that the speed of testing could be increased for samples that were collected from its borders. We also supported surveillance at points of entry, but also cascading that to facilities and to communities, such that in every village in the zones that we covered, there would be someone in that village called a village health team member that knows what COVID-19 is and can report if people have unexplained symptoms or deaths. And here we come to medical countermeasures, which is the primary interest of the people in attending this meeting. The efforts that we put to control the outbreak bought time for Uganda, sufficient time for evidence to be released to show that a simple, inexpensive steroid, dexamethasone, could be beneficial amongst patients with severe disease. And we were able to contribute to an Africa CDC statement that was then circulated to African states, including Uganda, to incorporate dexamethasone in their treatment guidelines. And that effort is ongoing. Convalescent plasma is something that has been used in the US, and in Uganda too, it's still investigational. And here we have universities also contributing to that effort. I mentioned remdesivir earlier for Ebola and how it was shown to be unsuccessful. Notably, remdesivir seems to have a broader spectrum when we look at it in vitro. And remdesivir also showed potential benefit for COVID-19 and was granted an emergency use authorization in the US, also for patients that had more severe disease. Our team, in collaboration with the University of Turin, was able to support a bioanalytical protocol for looking at remdesivir concentrations in biological samples. And that is published in JACC this year. In addition, we're going to be looking at remdesivir and drug-drug interactions between remdesivir and commonly used antiretroviral drugs, because tenofovir, for example, seems to share similar phosphorylation pathways with remdesivir. And this will mean that we would have evidence that would be suitable in local settings for people with HIV and that may also develop COVID-19. And so what have we learned? We know we can stop and slow down outbreaks if we act early and in a coordinated fashion, making sure that there are no gaps in the system for lab, surveillance, infection control. And we also know that these outbreaks are certain. Well, we can avert disasters if we plan ahead. And access to therapeutics and vaccines are likely to remain a challenge worldwide, because very little has been done for some of the diseases that we actually know can result in pandemics. So we need to act now for the known priority pathogens. I think we may have an excuse for not dealing with pathogens we don't know, but for those pathogens that we know, there is an urgent call to accelerate investigational efforts to create new treatments for these diseases. So we do have a lot of supporters that help our work continue, from CDC Foundation, USAMRIID, Henry Jackson Foundation, the EDCTP, a very strong response partner, Resolve to Save Lives, as well as strong scientific and technical expertise from the United States Centers for Disease Control and Prevention. Thank you.